Our next talk is being given by Dr. Ajai Seth, who is a consultant in SEM at London Bridge Hospital, and he's presenting on common upper limb injuries and problems in adolescents. He is Chief Medical Officer for Team GB Wheelchair Tennis and is a senior lecturer in sports medicine at King's College Hospital, where he lectures on all aspects of sport medicine and science. Over to you, Ajai.
Hi there, my name's Dr. Ajai Seth, and today we're going to be talking about common upper limb problems in adolescent sports medicine. So what we'll briefly cover is history taking, the key points we need to ask from our patients, some functional and developmental anatomy. We'll work through different body parts, starting at the chest and working our way down. We'll talk about the key considerations in adolescent sports in general and different management strategies. So with any history taking, the mechanism of injury is really, really important when you're trying to find out what happened to your patient and how they got injured. So with the upper limb, as with any other area of the body, there's lots of different ways you can get injured. Understanding the sporting technique is really important. So ideally getting some video footage of how they perform their golf swing or tennis stroke is ideal, because often what they're describing is very different to what you will see them doing. Load and volume, very important to understand what's going on there in terms of has there been any recent changes, and common things we often really want to focus on are, has there been any recent coaching change or technical change or equipment change that's led to the injury essentially. One key thing I always really try and focus on is the academic and parental demands on adolescents. So often, they'll be going through stages of their academic life or schooling that there's a lot of pressure on them to perform. A classic example was, going for a sports scholarship, for example, and there's a lot of intensity on them to perform a certain way. So it's trying to understand what their social history is. Also about their growth and development. So sometimes they'll be growing and they'll be going through a peak height velocity or growth spurt, and that's a key time of their adolescent years where they can get injured. Just to remember, like any other part of the body, lots of things that can get injured, from bony, ligamentous structures, nerves, muscles, and that has a real indication on how quickly the injury recovers and what type of rehabilitation they need. So just important to consider all those anatomical things. So we'll start off in the chest. So sternoclavicular injuries, some people may not be overly familiar with them, but essentially the clavicle is an interesting bone because it's the first bone to begin ossification, but it's the last bone to fully fuse. So the both ends of the clavicle don't really fuse until the early 20s. And if you've got usually quite a significant force going onto the clavicle, either from a forward to back or back to forward motion, that can put force on the sternoclavicular joint. And often patients are presenting with a pop that's felt in that area. There can be tenderness, but what we really want to look out for is posterior displacement of the clavicle, which therefore can potentially go into the mediastinum. And that's something that requires like a full cardiovascular workup and assessment, and obviously so urgent intervention if there is a suspecting posterior displacement. So in these images here on the X-ray at the top, you can see the arrows pointing to a mid-clavicular growth plate injury from a fracture, which you can quite clearly see on X-ray, and from the CT scan below, you can see there's actually been displacement of the clavicle in another patient, that is, and you can see it's almost compressing on the great vessels behind. So clavicular injuries itself, again, the clavicle is a very fascinating bone because it undergoes two types of ossification, intramembranous and endochondral. So intramembranous is the one that occurs in flat bones in general, and endochondral is the one that occurs in long bones. Usually there's a bit of force involved, so like RTA. Very interestingly, it's 8 to 15% of all pediatric factors, but half of those occur under 7. So usually there's significant force going through the clavicle in the adolescent years. So I normally see it on the rugby pitch, or I've actually had a few go-karting injuries, for example, that have had clavicular injuries. 80% of them will occur in the middle third, so the green area. Then the lateral third and the medial third is the less common. Often they heal very well, and if you've ever wondered why they look so horrific on X-rays, it's because there's lots of different muscles pulling the fragments in either way. So what usually happens is the proximal fragment goes up and the distal fragment goes down. And yeah, they heal very well in slings. But if there's lots of displacements or they're shortened, then yeah, surgical opinion is certainly warranted. ACJ injuries, so often, we're much more familiar with these, but the difference in adolescent patients is that the clavicle sits in a periosteal sleeve, which is essentially a thin film of tissue. So what may look like a ACJ dislocation actually is a metaphyseal injury or fracture, and you get displacement from them. The mechanism is very similar. So you can get a direct blow onto the point of the shoulder or fall onto the outstretched hand. They can present with bruising, deformity, mechanical symptoms, and the classic scarf test is usually positive. Again, do very well with conservative management regarding on the amount of displacement they have. You may be familiar with Rockwood classification. That's also applicable to pediatric cases, but there's a special pediatric classification in there. So just have a look out for that. You also may have heard of this term of osteolysis. So osteolysis essentially is a lateral clavicular growth plate injury. And I tend to see this in patients who are getting into the gym, doing lots more lifting, lots more overhead press, snatching, cleaning and jerks, that sort of stuff. So they're, into the weightlifting era. And essentially what you get is this sort of fraying of the distal clavicle, and that can be quite painful and quite irritative. So again, the management really is about understanding their loading, understanding how they're lifting, getting a lifting coach to look at their technique. Some people have different ranges in their shoulder, and they may not be able to achieve those types of ranges. Sometimes you can benefit from a corticosteroid injection to the joint to try and settle it down. ACJ resection is rarely done in adolescent years, but again, more common in adults. So another interesting anatomical part of the body is the proximal humerus. So essentially the humerus starts in lots of different growth plate centers. And by the age of 7, usually, but certainly by the age of 10, the proximal humerus will form a single epiphyseal center and one physeal plate. And this plate's very important because it accounts for like 80% of the growth of the entire bone. And yeah, a lot of proximal humeral fractures actually peak in the adolescent years, and you can essentially get 2 types. You can get metaphyseal fractures, which are generally more common pre-adolescence, or you can get epiphyseal separation, or the classical Salter-Harris type fractures, particularly 1 and 2. The diagrams on the left show that. So on the X-ray on the left now, you can see a metaphyseal fracture. And on the X-ray on the right, you can see a bit of widening of the proximal physeal growth plate. So very important to consider that in adolescent years. You also may have heard of little leaguer's shoulder. So that is essentially a stress injury. And this is actually much more common of what I see in a sports medicine clinic, because it's all to do with repetitive microtrauma with large rotational torques typically involved in throwing sports. And so essentially you get stress across the physeal plate of the proximal humerus, and it's most common seen in athletes between the ages of 11 and 13. You have to look at the throwing mechanics to understand where the forces are the most. And MRI is really, really useful at detecting these types of injuries. So management, again, it's about rest and restricting their play or restricting their throwing or number of throws, all about load management and scheduling, estimating their peak height velocity. And they can do other things, while they're resting. They can work on hand-eye coordination, cuff strength, other attributes, lower limb strength, that kind of thing. So just very briefly, we'll just have a look at, apophyseal injuries or growth plate injuries in general, generally more common during adolescent years. Very important to determine the peak height velocity and plan for it. So you might want to plan competitions or training. Also to do with their training programs and understanding which athletes they're competing with, and is it age appropriate or ability appropriate or size appropriate, and that concept is called biobanding. And strength and conditioning, very, very important to make sure you're supporting the joints with the appropriate muscular and endurance, as well as the flexibility of the muscles as well. So anyone who's done pediatric A&E will remember this. It's the ossification centers of the elbow. But actually, in adolescent years, what is more important is the age that these fuse. And as you can see on the right-hand column there, there's a huge variety in different ages that these fuse. So it's very difficult to tell what is an ossification center and actually what is an avulsion injury. Again, in the adolescent years, the green boxes are highlighting what are the most important fractures. So 80% of pediatric elbow injuries occur at the medial epicondyle apophyseal plate, and that peaks around the age of 10. And that's actually the most common thing we often see. You also get the traumatic injuries like radial head fractures, elbow dislocations, which can also occur in adolescent years, but again, usually trauma related. So the throwing adolescent elbow is again like the upper limb, very, very important in that there's different forces going through the medial aspect and the lateral aspect. So in the medial aspect, you tend to get more of a distraction, and on the lateral aspect, you get more of a compression. And that brings us to two different types of conditions. Where on the the medial aspect, you'll get little Leger's elbow, where the MCL ligament is pulling on the medial apophyseal plate, and the X-ray at above here can show there's just a bit of widening. On the left here shows a bit of widening of the plate. Where on the radial side, you often get the radial head abutting the capitellum, so that can produce a little of cartilage debris, which we call osteochondritis dissecans. The top left graph here is very interesting because it actually shows how similar the forces going through the elbow are to the shoulder, and that can be quite high. So you can reach up to, in adolescence, you can reach up to, usual Newton meter torques of 40, 50, but in professional sports people, you can even go into the 200-300s, which is a significant force going through these tiny ligaments in the elbow and the shoulder. So we have to mention the wrist. So the distal radial metaphyseal fracture is the most common fracture of childhood, and very important because, like the humerus, the distal radius actually contributes to a lot of the length that the arm will eventually have, and we worry about growth arrest from that point of view. So yeah, you often commonly get non-displaced fractures, but with more higher force transmission, fall onto outstretched hand or some form of impact. You can get displacement of the fragment, and how you would manage these all depends on the amount of displacement and the degree of angulation, which we'll have a look at in a second. But also you have to consider if there's been significant enough force to displace the fragments, are there issues anywhere else, fractures higher up or lower up in the wrist or even in the sternum or higher up in the chest. And these are just a few of the examples below of different types of fractures that can occur associated with distal radial fractures. So in terms of angulation, the general principles are, as the child gets older, you want the fracture to be less angulated. So you're less willing to you want at least less than 10 degrees of AP angulation, and dorsal angulation also less than 10. In terms of the apposition of the ends, which we call bayoneting, you want them to be really aligned. You're not going to give, when children are below the age of 10, you might allow for a little bit of poor apposition, but in the adolescents, that's unacceptable. You have to get it aligned. So often need a prompt orthopedic review, particularly with open fractures, and obviously assessing the neurovascular status is really important. So talking about wrist plate, growth plate fractures now, so not the metaphysis, but the growth plate. Again, Salter-Harris can classify this for us. Type 1 and 2 are really more common, but actually, fortunately, not often associated with growth disturbance, whereas type 3 and 4 are quite rare, but they are associated with growth plate disturbance. Type 5, interestingly, is more of the compression element of the growth plate, and you don't really see that in adolescents until they've had growth arrest and issues there later. We'll just briefly touch on growth stress injury, and actually, like the proximal humerus, You can often get growth plate injuries that can cause growth risk arrest. So it's the same principles. I often see this in divers or gymnasts who have repetitive compression on the wrist. So it's important to understand the sport that they're doing and why the distal radial growth plate might be injured. We'll just briefly touch on the dreaded scaphoid fracture. Again, in younger children, it doesn't ossify at all, but in adolescents, they have this retrograde blood supply. So again, you're worrying more about proximal pole fractures and waist fractures. And again, you're getting surgical opinion as required. So here you can see a non-union of a scaphoid fracture that hasn't healed. Last slide is just to make sure we look at the red flags always. So tumors, infections, or non-accidental injury, making sure we've considered all these things, particularly in adolescence years where they've got different pressures and social pressures going on them. So it's very important to just have you always thought about these other factors that may be happening? Have you got the appropriate imaging? Have you considered red flags? Lastly, always important to keep a very holistic opinion. There's lots of issues going on in adolescent sports medicine, particularly from the more social and performance pressures. So make sure you've covered all those factors. So thank you very much. Feel free to get in contact with me. My contact details are here. More than happy to answer any questions. And if you want to come down to clinic at any point at ISEH, you're also more than welcome to. Thank you.
So a few questions have come through for you. So first one is, do you have any concerns with teenagers trying to lift heavy weights on a regular basis?
Well, the first question is, how do you define heavy? But it is a general principle. Weightlifting in adolescence is absolutely fine as long as it's done with appropriate form, appropriate technique, and under appropriate guidance. And actually, it can be a really, really useful adjunct to training. So often you'll have adolescents who do a lot of training, a lot of sports like, for example, football, but it could be really well accompanied if they added in a strength program. I think there used to be old rhetoric around, oh, you shouldn't lift weights until you're an adult or until your older years, but actually you can start strength training and learning more about the form of how to lift weights and how to lift sensibly from a very young age. So it's not uncommon now for 8-year-olds plus to be in the gym and start moving and start lifting weights, and it helps proprioception. It helps develop muscle conditioning. It helps with a lot of other factors, and just really, really does balance training. So I would encourage all adolescents I see to really understand the principles of strength and conditioning training and actually get trained on it and begin to use them in their own training plans.
Fantastic, thank you. So a case study for you from a participant. They say, I'm treating a sporty 16-year-old with anterior recurrent subluxation of the sternoclavicular joint, SCJ, in the dominant arm. It's an atraumatic injury. So what are your thoughts as to the long-term prognosis and management in a case like this? It's obviously not, a lot of information, but what can you tell us?
So I think the first thing to say about that case is that it's actually quite common. And I know in the previous talk, we were talking about hypermobility and just general joint pliancy in adolescence. So it's not uncommon to get mobile segments, whether it's the sternoclavicular joint or whether it's the elbow, the shoulder joint in general. I would say, linking into what we were just talking about, strength and conditioning training, the vast majority of times they're not going to have a strong enough upper girdle to support the sternoclavicular joint, and by that I mean pectoral muscles, the shoulder girdle, the scapula itself. So it's about really tightening up the complex, what I like to call the thoracic ring. So making sure all components of the musculature around the thoracic ring are really, really steady. And you often find that as patients grow, a lot of these symptoms kind of settle down. So, I mean, slightly different if it was, like we said, posterior subluxation or posterior dislocations, but anterior subluxations is really, really common, particularly in the dominant side as well, if they're playing racket sports with the right hand, again, you might want to just see how much they're playing. If they're playing, 20 hours of tennis a week, you might say actually that's probably a bit too much, and just modify it from that point of view. But yeah, very, very common example, and something, if you take a more holistic approach, it's not actually about the sternoclavicular joint, it's more about just their training and their general lifestyle as well.
So pacing and load management through the upper limb, the shoulder, the sternoclavicular joint, and the scapulothoracic aspect of the shoulder is really important as well, wouldn't you say?
Yeah, and we're so used to talking about lower limbs in terms of kinetic chains, and we all know that from running and gait analysis and gait assessment. But the upper limb's the same. So, from particularly with non-impact injuries, from the point of contact, whether it's a racket or club sports, force gets transmitted up the body, and also you are creating force from the trunk down as well. So it's about identifying what are the weakest links in that chain, trying to strengthen other areas, and again, load management, as you say, Sarah, technique, all these things are actually more important than the structures themselves. So yeah, if you can usually counsel patients correctly and get them on a balanced program with the right training in place, then 9 times out of 10 you've solved the problem.
And how do you find that neck injuries interplay with upper limb injuries?
Again, so there is a cohort of patients who suffer with a condition called thoracic outlet symptoms. So that's essentially where a lot of structures are tight in the neck, and muscular structures can be tight in the neck, or for other reasons. But that can interplay as well. So, of course, the upper girdle neck assessment is always key, and making sure the neurovascular status of the arm is has been considered as well.